Welcome, everybody, to this month's TEPHI Grand Rounds. Excuse me. I'm Kathy Troisi. I'm a professor here at UT Health School of Public Health and also involved with the Texas Epidemic Public Health Institute. The mission of TEPHI is to keep Texans safe and the economy strong by strengthening our capacity and resiliency of Texans to respond to future infectious disease outbreaks, which we know we will have and indeed are having right now. So we work with a number of other institutions. We're a state agency, so obviously we work with Texas government. We work with a number of nonprofits, public health nonprofits, like the Texas Association of City and County Health Officials, other local health departments, the Texas Department of State Health Services. We also have relationships with business entities, looking at, for example, this supply chain, which, if you'll remember, during COVID was an issue. We collaborate with other academic institutions here in Texas, and then community organizations as well. We also offer training free to Texas residents, and we have a certificate in pandemic preparedness and response. This shows you the 4 courses and then a tabletop exercise to earn the certificate. It is free, as I said. It's asynchronous. You can do it whenever you want, 3 o'clock in the morning. So check that out. There's a QR code there. Or if you just, for any of the things I'm going to tell you about, you can go to TEPHI, TEPHI.texas.gov. We offer CE credits for the certificate, and it's free for Texas residents. We also have, on the next slide, some mini courses. These are more specialized courses. They're between 1 and 3 hours, again, free, asynchronous. And this shows you the online courses that we have available, and CE credits are available for these as well. Again, there's the QR code or the website or TEPHI.texas.gov. And there's lots of ways to connect with us. This gives you some of them, but again, texas.tephi.gov, you can find everything there. But as part of TEPHI, we have these infectious disease grand rounds. And because I think that's my last slide, right? I'm not controlling them. Oh, sorry, it's not. If you need closed captioning, you can click on live transcript. If you have questions, we'll get to those at the end. You can put them in the Zoom chat. You'll get a survey upon exiting. We'd appreciate it if you fill that out so we can always improve and make things better. And the webinar is being recorded. It will be emailed to you in about a week. You can find this webinar in about a week and our previous ones on our YouTube channel. Again, there's the website, but you can find it at tephi.texas.gov. And if our next Grand Rounds will be in July. If there is a topic that you're interested in, please let us know. You can put it in your survey, or email us at info@, I'm not sure what the email is. It's on the website, or you can find me. There aren't many Troisis. All right, our speaker today, I'm delighted to have with us Dr. Prion Appleby. He is the director of the National Prion Disease Pathology Surveillance Center, and is at Case Western Reserve University School of Medicine. He received his MD from Georgetown University School of Medicine and completed a psychiatry residency at the Johns Hopkins Hospital, where he also completed a geriatric psychiatry fellowship. He's a neuropsychiatrist who treats and researches cognitive disorders. Do you do work on trouble speaking? His clinical and research interests include prion diseases, frontotemporal lobar degeneration, and young-onset dementias, which there's just an article today or yesterday about how prevalent incidence is down, but prevalence increasing, I believe. He is also medical director besides his academic appointments. He is medical director of the Creutzfeldt-Jakob Foundation and a board member of the Cleveland chapter of the Alzheimer's Association. In his spare time, he's leader of the Cleveland Alzheimer's Disease Research Center's clinical core and co-leader of the neuropathology core and site PI for several national dementia studies, including all FTD. I don't know how you pronounce that acronym, but it's about frontotemporal lobar degeneration and the Alzheimer's Neuroimaging Initiative. Okay, now that I've botched that, welcome, and we're all excited to hear about prion diseases.
Thank you very much, Kathy. I appreciate it. And thank you for the organizers for inviting us to come talk about prion disease. So I realize there's a lot of different backgrounds on the call. So this is a kind of a general overview. I've tried to touch on lots of what may be pertinent to most people. But I'm sure there'll be some details that you may think is missing. That's fine. You can always put them in the chat. These are my disclosures. So for today, we'll review what we mean by the word prion and also refer to the prion paradigm, what that means, and also how that's applicable to other illnesses. We'll talk about a lot of the clinical features of human prion disease, how you diagnose it, what it looks like, the different types. And then we'll end with some of the prion disease transmissibility issues in the healthcare setting. So first off, of course, underlying all of prion disease is the prion. Prion stands for a proteinaceous and infectious particle. It's a transmissible protein that is unlike any other infectious organism because it doesn't require nucleic acid. It's protein only. Because of that, I do not consider it infectious disease. I call it a transmissible illness. And that was the original name for these illnesses, a transmissible spongiform encephalopathy. So underlying the prions, we all make normal prion proteins. That's the structure on your left. In our field, we call it PRPC, which stands for cellular prion protein. It primarily has alpha helices, and it has a variety of normal housekeeping functions in our body, primarily expressed in our brain and in our gut. It is a second messenger molecule and also has some neuronal housekeeper functions as well as embryonic development. However, it becomes an issue if it changes its 3D structure to the pathologic disease-associated form, which in our field we call PRPSC, which stands for the scrapie protein. Scrapie was the first prion disease that was discovered in animals, in sheep and goats. And it's the same protein. The only difference is the 3D structure. So you'll see that the structure on the right now actually primarily has beta-pleated sheets. And that gives rise not just to its transmissible nature, but also its neurotoxic nature. And unfortunately, also the one thing that we all know for it, and that's that it's very hard to decontaminate it. And these prions engage in the prion paradigm. Now, we used to think that this was solely pertinent to prion disease, but we now know that pretty much all other neurodegenerative illnesses are due to basically abnormal conformations of proteins that we normally make. And it changes their 3D structure and they propagate just like prions. So examples of this are alpha-synuclein in Parkinson's disease and multiple system atrophy, TDP-43 in ALS or FTD, or A beta and tau in Alzheimer's disease. So these are all examples of kind of the same process. Of course, there's one important difference, and that is most of them are not transmissible between individuals. And of course, there's no zoonotic transmission of those illnesses, whereas there is with prion disease. But the underlying premise for all this with the prion paradigm is we all make those normal prion proteins, the yellow dots on the top, PRPC, and then using a process called template-directed protein misfolding, the abnormal form comes into contact with the normal form and converts it into itself in this kind of autocatalytic mechanism. You get this exponential rise in the disease-associated form, and that's where you get propagation throughout the brain, and then disease spread. So again, this is first discovered with prion disease, but at least this propagation process in vivo is also very similar in these other neurodegenerative diseases that I mentioned. The only way to definitively diagnose the disease is through neuropathologic examination, and this is what we do at the Prion Center. We do three tests for this. We do H&E staining, which looks at the structure of the brain parenchyma. You can see that the arrow is pointing to this large vacuole, which is what gave rise to the original name for these illnesses, which was a spongiform encephalopathy, due to the sponge-like nature of the brain, due to the neurotoxicity caused by the prion proteins. You can then do immunohistochemistry, where we take an antibody and stain the brain parenchyma for that. And you see the brown deposits, those antibodies, of course, against the prion protein itself. We can do something a little bit similar with Western blot, in which we take brain homogenate and subject it to protease K. That's what these pluses are. Now, protease K should eliminate all proteins. It digests them. However, because of the hardy nature of the prion protein, it does not digest the disease-associated form of the prion protein, and it persists. So if you were to do a Western blot using the antibody against the prion protein in brain tissue subjected to protease K, you see that it persists. And these are all pathognomonic for prion disease. So now we're going to move on to the clinical features of human prion disease. Of course, there are other animal prion diseases. Scrapie, as I mentioned before, everyone's heard of bovine spongiform encephalopathy, which is affectionately called mad cow disease in the media. But there's also something called camel prion disease, which we don't know a whole lot about, affecting camels and dromedaries. And of course, in this country, we have something called chronic wasting disease, which affects deer and elk, basically the cervid species, and I am going to talk about that later on. But for the purpose of the rest of this talk, we're going to talk about human prion disease. A human prion disease, most people think of it, and the first thing that they think of is mad cow disease. However, most cases of prion disease are what we call sporadic, and that means it just happens with no known cause. And this is true for most neurodegenerative illnesses. If you look at most neurodegenerative illnesses, they're sporadic, and really the predominant risk factor is age. And that's probably because most of these illnesses come about, including sporadic prion disease, due to post-translational modification of the protein that causes it to be disease associated. In our illness, we like to use a lot of different terms. So sporadic prion disease includes things like sporadic CJD, sporadic fatal insomnia, or variably protease sensitive prionopathy. In our country, about 10% of cases are due to genetic mutations of the prion protein gene. So these are inherited forms of the illness, and they have a variety of names, including genetic CJD, fatal familial insomnia, and Gershman-Straussler-Schenker syndrome. And then the ones that you hear the most about, and the ones that, of course, epidemiologists and public health officials are the most concerned about, the acquired forms, are thankfully the least common. And they're well under 1%. This includes things like Kuru, iatrogenic CJD, and variant CJD, which is what we call CJD in a human due to eating meat contaminated with bovine spongiform encephalopathy. And we'll talk about the acquired forms in fairly good detail because of the audience today. Unfortunately, prion disease is a very rapidly progressive dementia. So if you look at this Kaplan-Meier curve, you'll see one thing, and that is it's 100% fatal, unfortunately, and it happens very rapidly. So the mean illness duration from illness onset until the person passes away is about 4 to 6 months. In our country, the average time from diagnosis to death is about a month. But what you'll see is that if you look at the 1 year mark, we do still have patients that are living. About 20-25% of patients will live longer than a year. Of course, the vast majority will be deceased within 2 to 3 years, but occasionally, or very rarely, you'll see people that will live longer than that. And that can be due to a variety of things, but usually it's due to life prolonging measures. So rapidly progressive illness, unfortunately. And of course, people know the epidemiology. The one term that's thrown around often is the 1 in a million. So hopefully our public health officials know that that's an incidence number. So that means the number of new cases of prion disease every year across the general population. However, CJD and other forms of prion disease do not just they don't affect really young people that much. They primarily are illness of mid to late life. So if you look at the whole population, it is true that the incidence is about 1 to 2 per million per year, depending on how hard you look at it. But if you look at the older population, so those equal to or greater than 65 years of age, that incidence is closer to 4 to 7 per million per year. Conversely, if you look at those that are younger, under the age of 65, the incidence is about half. So again, this is very intuitive, I think, to public health officials, but oftentimes we're speaking to clinicians or family members trying to understand, how common the disease is. And when people try to understand how common it is, I find that it's usually um, more psychologically appealing to people to refer to the frequency. So one way to do that is to look at the number of UF deaths per year that are attributable to prion disease, and that's about 1 in 6,000. That also equates to lifetime risk. So we all have a lifetime risk, about 1 in 6,000 chance of developing prion disease during our lifetime. Um, that's not common, but it's probably not as rare as most people thought. If you look at a stadium, especially football stadiums in Texas, you'll expect a handful of people in that stadium to eventually develop the disease. So, not common, but not super, super rare either. So, and I'm always astounded by this statistic when I give talks to people in Texas. You have an absolutely huge population. Um, but if we look at the epidemiology of prion disease in Texas, you have about 31 million people in your country. So we would expect about 31 to 62 new cases of prion disease every year. If we assume that about 20% live longer than a year, that's a carryover of 6 to 12 cases every year to the following year. So it wouldn't be unusual, and actually would be expected to have anywhere from 37 to 74 active cases in actually Texas, not Washington. You can tell where I did the last grand rounds, and in Texas at any one time. So again, I'm not saying this is common, but certainly you'll be seeing that, especially if you're in an academic medical center. These illnesses are definitely around. So oftentimes we get calls at the Prion Center, and we like these calls because we want to be notified that we saw a certain number of CJD cases last year. We're concerned. So I think it is helpful to go over the process of how we investigate potential clusters. These clusters are primarily investigated by CDC, your state local health department, as well as our assistants. And these are the steps that we take to investigate clusters. First, we have to verify that it's actual prion disease. And most of the clusters that we investigate, I would say 99%, when we look at clusters, we find that at least one case winds up not being prion disease. And that's pertinent because when you look at rare diseases, you're looking at small numbers. So if you're looking at small numbers and you automatically remove 1 or 2 cases that are not pertinent to your investigation, then it may not even be a cluster anymore. It's then important to verify the type of prion disease. In clusters, we're primarily interested in people that may have a common exposure. So if we have a known cause of prion disease, say, for example, a genetic mutation, we're probably not going to include that case in the investigation because we know the cause of it. We also want to verify that the number of cases being investigated is higher than what is expected. As you all know, randomness and epidemiology can play funny numbers games. And oftentimes, when you look at rare diseases, you can have a wide breadth of expected numbers, as you saw in that earlier slide for epidemiology in Texas. So you have to see whether or not it is outside the realm of being expected. And the analogy I like to use is if you take a bag of rice and you throw it on the ground, it will inherently cluster. Now, that doesn't mean it's not a random event. That's what happens, especially when you look at rare numbers of things like rare diseases. We then have to verify the likelihood that these people do have a common exposure. As you'll see when we start talking about acquired prion diseases, there are not a whole lot of recognized exposures for prion disease, and they all have very similar instances. So, for example, that doesn't include things like exposure to COVID or the COVID vaccine. And with that, we have to verify that the incubation periods make sense with what we know with the disease. These illnesses used to be called slow viral illnesses. This is before we knew that they weren't caused by viruses. But the slow was very pertinent because incubation periods for prion disease are measured in years to decades, not days, weeks, or months. So if you have someone that has a potential exposure and they got sick, say, a week later, that really doesn't make sense with what we understand about prion disease incubation periods. So these are all things that we look at. And again, we want people to notify us, but we also want you to understand what we're going to look for. And that's very pertinent. So although the only way to definitively diagnose the disease is through neuropathology, we can make a very reliable clinical diagnosis of CJD during life, and we refer to this as probable CJD. And there's two main criteria for this. There's the old criteria and then the new criteria. So the old criteria is kind of your basic bread and butter behavioral neurology, where you identify a clinical syndrome and then match it with a suggestive diagnostic test. So in this case, we're looking at the clinical syndrome of CJD, which includes a couple of clinical signs matched with dementia, and that can include myoclonus, which is a jerky-like movement of the extremities. It can include cerebellar symptoms, which can include an ataxic or drunken-like gait, or visual symptoms, sometimes something referred to as cortical blindness, or hallucinations, depth perception issues. It can include pyramidal or focal weakness or extrapyramidal symptoms, which looks like Parkinsonism. Or in very end stages, it can lead to a state of akinetic mutism, which is lack of volitional speech or movement. Now, of course, you can see this in other cortical forms of dementia, but it is part of this criteria as well. So you have this clinical syndrome that mimics CJD, and then you have a variety of diagnostic tests that you're going to try to match with it. So that can include things like periodic sharp wave complexes on electroencephalogram. It can include the presence of elevated 14-3 proteins in spinal fluid in durations less than 2 years, or it can include a variety of brain MRI abnormalities that are fairly sensitive and specific for prion disease, matched to the clinical syndrome. So this is all well and good, and we still use these criteria to make diagnoses, but there's a new criteria that has, changed not just the clinical diagnosis of prion disease, but I think especially the epidemiologic surveillance of prion disease, and that includes this newer test called RT-QuIC, which stands for real-time quaking-induced conversion, which in our country we do in spinal fluid. It's so specific for the disease that you can make a probable diagnosis with a positive RT-QuIC in the setting of any neuropsychiatric syndrome. So that's a pretty light criteria, and that really is, I think, testament to the specificity of such a diagnostic test. And we are going to talk about this later. Now, the problem with this is we have, these criteria that are very, very powerful, but the patient doesn't walk into the clinic or the hospital necessarily with a clinical picture that screams, I may have CJD. In fact, if you look at the initial clinical presentation of people with prion disease, the plurality will have a non-specific cognitive syndrome in which the clinician at least shouldn't consider a diagnosis of prion disease outright. They should probably consider things like Alzheimer's disease or other forms of dementia first. 17% will present with a pure visual presentation. A lot of times these are misdiagnosed as stroke because they tend to be rapid and they tend to have MRI abnormalities that can mimic what you can see in a stroke. 15% would present with a non-specific affective illness, like, say, a mood or anxiety syndrome, of which probably no one would suspect prion disease. Only 13% initially present to clinicians with that kind of classic CJD syndrome of dementia or cognitive impairment, paired with problems with gait and myoclonus. So the problem with prion disease, much like other neurodegenerative illnesses, is oftentimes the best diagnostic tool we have is time, meaning that the patient has to clinically evolve to a point where there's clinical suspicion of the disease. So you can have the most powerful test in the world, like RT-QuIC, but if you don't know to actually order it on the patient, you might not capture the disease until later in the disease course. So what should raise clinical suspicion? And these are just my general suggestions. Of course, if you know someone's at risk for prion disease because they belong to a family or they have a known exposure to prion disease, they should probably be considered for prion disease if they have any clinical symptom that could mimic that. If they have dementia with atypical neurologic signs, say, for example, gait ataxia or myoclonus, especially early in the disease course, then prion disease should be suspected. These are not, especially typically not early symptoms that you see with other forms of dementia. They're rather atypical. If you see any rapidly progressive neurodegenerative illness, then you should consider prion disease. And then if you have a patient who you've diagnosed with some other neurodegenerative condition, but as you see them in follow-up, they start having an atypical progression for that disease that you initially diagnosed them with, then you probably should at least consider prion disease for your differential. And then, of course, if you have any suggestive diagnostic tests, whether that be brain MRI or EEG, then you should at least consider it in your differential diagnosis that it could be prion disease. So moving on to some of the diagnostic tests that we use. This is an example of an EEG. Sometimes people with prion disease will demonstrate a very specific pattern called periodic sharp wave complexes. This is very helpful if you see it because it is fairly specific for the disease, but not all cases of prion disease will have it. And in fact, if they do have it, it's only present, say, maybe 2/3 of the way through the illness. So nowadays we have much better diagnostic tests. So we frequently do not diagnose the disease based off EEG findings. We're typically using EEGs to rule out other mimickers. For example, status epilepticus or other seizure disorders that may mimic some of the symptoms of prion disease. MRI, I think, has really changed our ability to diagnose prion disease as well as our ability to diagnose it early. And we use diffusion weighted imaging sequences, which is pretty much done in all hospitals in this country at this point. We use it often to look for stroke, for example. So it's almost always included in any brain MRI. And we look for hyperintensity in either the outside part of the cortex called the cortical ribbon or the middle part of the brain called the basal ganglia, the caudate and putamen. Now, most cases of prion disease will have hyperintensity in both areas, but occasionally you'll have cases of prion disease that will just show hyperintensity in one or the other. This is a fairly sensitive test, and it's also fairly specific as well. What's important to know is it's also a pretty common early diagnostic finding in prion disease. So, although you may have only 30% of people with prion disease that come in with nonspecific cognitive symptoms, a lot of times a neurologist will do an MRI, and this may be the first initial suggestion that it could be prion disease. So again, they don't have that full clinical syndrome, but they have cognitive symptoms with an MRI that looks like prion disease, and then that results in the patient getting a spinal tap and RT-QuIC being ordered. So I think this really has helped earlier diagnosis, especially in cases that may present with a kind of a slower insidious onset where you don't have a kind of common CJD presentation. We do a variety of spinal fluid tests. So at the Prion Center, we do 3. 2 are markers of neuronal injury, 1433 and total tau. Total tau is probably the more helpful of the two. The higher the value, the more likely it is to be prion disease. Although, of course, you can see other mimickers because it's just markers of neuronal damage. It's not disease specific. And then we do that disease-specific test I talked about earlier, RT-QuIC, which actually detects the abnormal prion protein itself, which is what makes it highly specific. The way RT-QuIC works is it takes advantage of that prion paradigm. And if you know any basic biology and familiar with PCR, polymerase chain reaction, in which we use that to amplify strands of DNA, it's kind of the same thing, but we're doing it for proteins. So at the premise, we take a 96 well plate. We add the substrate for the reaction, which would be normal recombinant prion protein. We add the sample, which presumably has the disease-associated form of the prion protein in it. Thioflavin T, which would bind to any abnormal form of the protein if it fibrillizes. Then we put it into a shaking incubator for up to 60 hours. And that kinetic energy, if prion protein is present, will amplify and convert the normal prion protein substrate into the abnormal form. fibrils will form, diaflavin T will then bind to the fibrils, and you'll get these real-time phosphorescent curves that really you would only expect to see in prion disease. So importantly, it's way more sensitive than most of our diagnostic tests. It has a sensitivity in our country of about 93%, and the specificity is much higher than our other diagnostic tests. So in our country, it's about 99% specific. We do occasionally have false positive. It's extremely rare. We maybe get one every other year, and there doesn't seem to be any rhyme or reason to false positives. So it's probably things like assay or lab error, um, but very, very specific compared to other tests. And this is true across countries that do this test. So another common question that we get at the Prion Center is I have a case of suspected prion disease. We did the spinal fluid analyses. Their 1433 and total tau proteins were elevated, but their RT-QuIC is negative. What should we do with this patient? So our recommendation is re-examine the diagnosis. You should always question your diagnoses, especially if things aren't matching up the way that you would expect. So look at the clinical phenomenology. Does it match what you would expect with prion disease? And more importantly, does it match with other conditions that you maybe should also consider? A lot of these patients will have a rapidly progressive dementia, and there's this very detailed workup that we would recommend for that condition, and it's quite intensive. So we would recommend that you do proceed with that if it hasn't already been done. A lot of times, just by chance alone, you'll have a positive finding when you do that many tests, but we do ask that you follow up on those positive findings just to make sure that it's not pertinent to your specific patient. We also ask, are there other diagnostic tests that we use in prion disease that are suggestive of prion disease? For example, do you see periodic sharp wave complexes on EEG or that brain MRI abnormality that I found you? Because keep in mind, although we do have that powerful diagnostic criteria that includes RT-QuIC, we can still make a probable diagnosis using other diagnostic tests in the right clinical setting. And then, of course, this is really should be the last realm of what you should consider. And if you really, really think it's prion disease, everything else has been ruled out, and then and only then do you think of the really rare prion diseases like sporadic or fatal familial insomnia, which is a genetic prion disease, Gerstmann-Straussler-Schenker disease, another genetic prion disease, and then the ultra-rare variant CJD in our country. So really, these should be considerations of last resort and should be done in collaboration with specialists. If I could, lay down one clinical caveat that I think is extremely helpful, and that is if we look at our case series in the span of the last 3 years, we find that for sporadic CJD, all of our cases are positive by either RT-QuIC or MRI. So it has a combined sensitivity of, in our series, it was 100%, but I never like to say something's 100%, so I say over 99%. So if you have a case of suspected prion disease, it's negative by RT-QuIC and brain MRI, please consider other alternative diagnosis because it's more likely that you're missing something else than you have one of these extremely rare prion diseases. So moving on to genetic aspects of the disease, we all have the prion protein gene. Above are the genetic mutations that cause disease. There's probably about 40 to 60 different genetic mutations. We do have disease-altering polymorphisms in green below, but we mainly care about the genetic mutations when it comes to clinical care. What's important to know is that not all mutations are considered equal. There's something called penetrance, which is the likelihood of developing the illness if you carry the mutation. That can be quite variable depending on the mutation. So a lot of mutations of the prion protein gene include things like P102L or E200K, which are very highly penetrant, meaning that if you have the mutation, you're very likely to develop the disease. But there are some mutations where actually you're not that likely to develop the disease. You have a likelihood of 10%. And what's important to know, and as you would probably expect, that these lower penetrant mutations have a lower positivity of family history compared to the ones with the higher penetrant mutations. And the reason why I go over this is if you do find a case of genetic prion disease, it's important to know what mutation it is and very important to know what the penetrance is because the family is going to want to know that. So if you do come across the case and you need help calculating, the most up-to-date penetrance of that mutation for when you talk to the family, we're happy to help you with that. Just let us know, and we can tell you a percentage or percentage range, and the family would be very appreciative of that, I'm sure. So again, there's a couple of named genetic prion diseases. One is called genetic CJD. It's the most common genetic prion disease. In our country and around the world, the most common mutation is E200K. Makes up about 60% of cases. E200K is also the most common mutation in Texas. It's very clinically similar to sporadic CJD. The symptoms are similar, the duration is similar, and often the diagnostic test that we would use to diagnose sporadic CJD would be positive. So, of course, the way to definitively diagnose it is the right clinical setting in the presence of a genetic mutation. So, genetic testing would be recommended. There's another genetic prion disease called fatal familial insomnia, which arguably sometimes does not look like a prion disease. It's due to one specific mutation, and neuropathologically, it primarily affects the thalamus. So that's why you see kind of a different clinical phenotype with these cases. So their initial symptoms include things like insomnia, neuropsychiatric symptoms of hypervigilance, and autonomic instability. They can develop, there's typical symptoms of prion disease like dementia myoclonus, but they typically occur later in the disease course. And unfortunately, a lot of the diagnostic tests that we would use to diagnose sporadic CJD would be negative in FFI. You can use other helpful diagnostic tests like a sleep study, which I've never really seen used correctly to diagnose the disease, or hypometabolism in the thalami and brain FDG PET or SPECT. But really, the ultimate thing you should be going for is genetic testing to look for that genetic mutation, because that's the way you definitively diagnose them. Now, there is, not to make things more complicated, but there is a sporadic equivalent to fatal familial insomnia that we refer to as sporadic fatal insomnia. This is extremely rare. We've only had about 30 cases of this in our country over the last 30 years, and it looks identical to FFI. The only difference is there's no genetic mutation because it's sporadic. Then there's Gershman-Straussler-Schenker syndrome, which really does not look like a prion disease at all from what I've described. It presents with kind of focal, cerebellar, or Parkinsonian signs early, and you can develop dementia and other typical CJD symptoms, but that's usually at the very end of the illness. And the thing that really makes it not look like other prion diseases is these are long duration illnesses. They're measured in years, decades. So the average duration that you see with most GSS cases is about 5 years, but you can see up to 20 years. So again, when you hear that, you usually don't think of prion disease. So a lot of times these cases are missed. A lot of the frequent diagnostic tests we use to diagnose prion disease are negative in GSS, but sometimes MRI will be positive. Sometimes RT-QuIC is positive in about 2/3 of cases. But again, if you suspect genetic prion disease, so you see family history of about half the families affected by this kind of, neurodegenerative illnesses that affect the cerebellum, and all other genetic testing is negative, you probably should do prion protein genetic testing to see if it could be GSS. Now, a lot of times people ask, well, why would people even want to know if they carry the mutation? And nowadays, we see this a lot in our families, and you see it in other neurodegenerative genetic conditions as well, is you can do something called pre-implantation genetic diagnosis with in vitro fertilization, where you can do IVF, test the embryos, and only implant the embryos that don't have the mutation. This is very empowering for families and eliminates the disease from the family. And we can definitely help you with that if that's something your family is interested in. So moving on to genetic prion disease, this all started with Kuru. Of course, Kuru affected the Foray linguistic group of Papua New Guinea. It started with a rapidly and ultimately fatal ataxic syndrome that only affected women and young children. And this attracted a lot of attention worldwide. People thought initially, because of the pattern that I just described, that maybe it was a genetic illness. Then Australia started colonizing Papua New Guinea. Anthropologists got involved and started studying these very interesting cultures, and they noticed that in this culture, they engaged in ritualistic endocannibalism, where they would consume the body of the deceased out of respect for them. Interestingly enough, it was only the women and young children who partook in those feasts. And this led to basically Long story short, evidence that it was transmitted through ritualistic endocannibalism. So the thought was that maybe someone in this tribe initially had sporadic CJD, but it was perpetuated throughout the tribe due to this endocannibalism as part of their death rituals. We've learned a lot. So first, we learned that these diseases are transmissible, but because we know when Papua New Guinea was colonized and cannibalism was outlawed, we can estimate incubation periods. And we've learned that incubation periods for Kuru can estimate anywhere up to 52 years. So again, this is why it was initially called a slow viral illness, because these very long incubation periods. So iatrogenic or medically transmitted CJD can also happen. We don't see this too often now because we know what causes prion disease. But in our country, the majority of cases were due to contaminated human growth hormone that was derived from pituitaries from cadavers who presumably had died from CJD. So it was basically injected into children of short stature, people with neurodevelopmental illnesses that had growth hormone deficiency. And unfortunately, these people developed CJD later on. Now, it's important to note that of all these people that were exposed to contaminated human growth hormone, depending on the country, only about 1 to 3% of people actually developed CJD. So it has a relatively low attack rate despite the exposure. There are other people that were exposed and got iatrogenic CJD from dermatographs that were also taken from cadavers who presumably passed from prion disease. Corneal transplants, which our country mitigates by corneal deferrals, and anyone who has any neuropsychiatric symptoms. Of course, for dermatographs, we now mostly use synthetic, and for growth hormone, we use recombinant growth hormone. So those exposures are eliminated. So really, nowadays, the only pertinent exposures through neurosurgery. And even the neurosurgical transmission cases we know of, we've only had about 4 to 6 cases, depending on the criteria you use. They all occurred in the last century. So, as we'll talk about later, you do need to take special precautions to completely remove prion infectivity from instruments. However, that factor, that epidemiologic fact, would suggest that current sterilization techniques are probably removing the majority of infectivity. And there have been lab studies that have shown that. You'll see at the very bottom blood transfusion, and that is a very distinct scenario, and that is only with variant CJD, the kind due to eating meat contaminated with mad cow disease. We do know that that's transmissible by blood. There's no epidemiologic evidence that non-variant forms of prion disease are transmissible by blood, and this has been through epidemiologic studies done in our country and multiple others. Variant CJD is different because it's orally acquired and it also seeds lymphoreticular tissues, which of course is important for blood component production. So it's the thought that that's why variant CJD is transmissible by blood and only variant CJD. So as you can see from this, there are very specific scenarios that are required for transmission between individuals, and they're very hard to come by, especially nowadays. Of course, the thing that complicates all this is these very long incubation periods, again, measured in years or decades. Moving on to variant CJD, again, this is the kind due to eating meat contaminated with bovine spongiform encephalopathy, typically presented in young individuals. We're talking about teens, 20s, and 30s. Longer durations over than a year, and they typically have early psychiatric or sensory symptoms. As we'll see by the MRI in the corner, the MRI looks different. We look at flare sequences as opposed to DWI, and the characteristics may change with longer incubation periods. We don't see a whole lot of variant CJD, maybe one case every 3 to 4 years. And they do look a little bit different clinically, and that's probably because these are older individuals, and that age is probably modifying their clinical presentation to some extent. So that's why we really encourage autopsy, because the only way we would probably catch these cases, not by clinical criteria, but by neuropathologic examination. So despite millions of people being exposed to bovine spongiform encephalopathy, fortunately, worldwide, we've only had a total of 233 cases of variant CJD, most of which have occurred in the UK, as you would expect, because that's where the BSE epidemic occurred, followed by other European countries that received exports. If you look at the US, we've only had 4 cases of variant CJD, all of which were thought to have been acquired overseas. This is kind of a graph of the epidemiology of the incidence of the death due to variant CJD. The BSE epidemic occurred in the 1980s, carried through to the 1996. And then you see that we have about a 10-year incubation period. Now, the reason why 1996 is important is because BSE is not a naturally transmitted illness amongst cows. It's basically we induce kuru in cattle by re-feeding cattle to one another. Once that practice was stopped in 1996, it stopped the propagation of BSE amongst cattle and virtually removed exposure to humans. But again, that took time. Again, this graph starts at stops at 2011. If we were to continue, you would see that maybe every 3 to 4 years we'd see one case. So that's the problem with these illnesses. You get really long tails because of these prolonged incubation periods. So one could ask, well, if multiple people were exposed, millions probably, we've only had 233 cases to date, are people silently incubating the disease? And in fact, we can answer this question, and the UK did, because as I said before, variant CJD also resides in lymphoreticular tissues, things like appendices. So the UK did look at discarded appendectomy samples, screened them for prions, and they found that 16 out of over 30,000 appendectomy samples that were screened were positive for prions, which we'd only expect in variant CJD. What is really interesting is it didn't differ by birth cohort. So the uh, subject could have been born before, during, or after the BSE epidemic. It didn't matter. So that would suggest at least, you know, probable low level infectivity still, although we don't know why that would be the case. All genetic backgrounds were represented. So it's estimated infection prevalence of 1 in every 2 to 4,000 Brits are silently incubating the disease. This led to blood deferral policies. So that's why if you tried to get blood, they would say if you lived in the UK for a certain amount of time during certain years, can't get blood. Now, the US has rescinded blood deferral practices, and that's true for most countries at this point because it's thought that the exposure was so long ago and the risk is so low and the need for blood is so high that it eliminates the potential for practical risk of blood transmission at this point in time of variant CJD. So although we don't have a lot of mad cow disease in this country, unfortunately, we do have this disease I mentioned earlier called chronic wasting disease, which is a disease of cervids. And it's probably the most easily transmissible prion disease amongst its own species. It's secreted in urine, saliva, and feces. It contaminates the environment, which is very hard to get rid of. And of course, unfortunately, these are free-ranging animals. So it's very hard to test and call them like you would with domesticated cattle. So this is really a huge problem. This map of affected areas, affected counties of chronic wasting disease just keeps really rapidly expanding. It's really sad to see. We're now up to 36 states, 4 Canadian provinces, multiple other countries, some due to import from US chronic wasting disease affected cervids, but some from their own chronic wasting disease seems to develop sporadically over there. This is really why we exist still at the Prion Center, because this is a huge concern. People eat deer, and deer contaminate the environment that then cattle and other production animals graze on. So this is a huge potential threat to human health. And although we have no evidence that chronic wasting disease has transmitted to humans, that doesn't mean that it hasn't already occurred because of these long incubation periods and things like strain variation. And it doesn't mean that it won't occur later. So it's really important to do longitudinal surveillance of this, especially neuropathologic surveillance, because that's really the only way to definitively know if it's prion disease, but more importantly, to know what type of prion disease it is or to detect novel prion diseases. I know I'm running out of time, so just know that all experimental treatments have unfortunately failed. You probably, if you're familiar with prion disease, know that there is a current trial looking at antisense oligonucleotides in early stage symptomatic prion disease. Unfortunately, it's closed for enrollment. The premise is that by decreasing the production of the normal prion protein, you reduce the fuel to the fire of the disease. There are other potential studies that will happen in the future that would also look at this approach. So, although past trials have not been successful, we do have hope that hopefully we can find something that will have some impact on the disease, and we do hope to see more clinical trials in the near future. Until then, it's symptomatic treatment, kind of your basic bread and butter, behavioral neurology or geriatric psychiatry. So I want to end with just discussing some aspects of prion disease transmissibility, specifically in the healthcare setting. And I'm going to lead with a quote that my predecessor used to always say, and that is that the fear of prion disease is more infectious than prion disease itself. As you've seen with iatrogenic cases, there are very specific circumstances. And in the lab, it's extremely difficult to transmit prion disease. You have to really take pains to do specific things. So for routine clinical care, standard precautions only. You're not going to be in any of these scenarios in which you would be at risk of coming into contact or having prion disease being transmitted to you. So there's no need for gowns, masks, or isolation. This is all over the CDC's website, our website, and the CJD Foundation's website. So please consider the family. They're going to see that. And if you do these other more extreme tactics that aren't needed, they're going to be freaked out, and that's not fair to them. However, things do change if you're dealing with highly infectious material, and that is mainly brain tissue. So this is only pertinent to neuropathology as well as neurosurgery. If you do engage with any suspected or confirmed case of prion disease in those instances, you do have to take special precautions. These are outlined. I'm not going to go over them in detail. My personal opinion is the best approach is to not have to do this. Screen patients. If there's any suspicion of prion disease, sequester instruments. You can always hold on to them. Wait until the diagnosis is more clear. If you find out it's a different disease, you can, reintroduce those instruments into circulation. If you find out that, it is prion disease, you can either discard the equipment or you can sterilize them appropriately according to these criteria. Spinal fluid is considered theoretically transmissible. It's not transmissible in any animal studies or human studies. We do not recommend any increased decontamination or procedures with that because you're not going to be in any instance in which you would transmit prion disease. You're not going to reuse the spinal fluid needle, and you're not going to drink the spinal fluid. You're not going to inject it into anyone. You're not going to put it in anyone else's brain. So there's really no vector for transmission in that instance. And again, it's considered low infectivity based only on theoretical implications. As far as lab is considered, the same thing with the lab. I mean, there's no possible vector for transmission when you run these things through your analyzers. And if you choose not to do that, that's poor patient care. And I can guarantee you've already run CJD specimens through your analyzers. There are plenty of cases that you probably had no suspicion of prion disease that have done that. So it's really not practical to do that. And I know a lot of equipment will say that, but it's really unfounded and impractical and really poor patient care. So in summary, there are three main causes of prion disease: sporadic, genetic, and acquired. Clinical presentation, as you can see, is quite variable, but it's usually distinguishable from other neurodegenerative conditions. Neuropathologic examination is the only way to definitively diagnose and type the prion disease. We'd strongly encourage pursuit of autopsy as well as long as the family's willing. A reliable clinical diagnosis, however, nowadays can be achieved with brain MRI and RT-QuIC. So if you know anything, don't get anything from this talk, just know that there's a lot of resources in this country. There's us. We do clinical testing on spinal fluid. We can do genetic testing on blood. We have a CDC funded autopsy program where we coordinate cases of suspected prion disease, their autopsy and neuropathologic examination free of charge. We'll take care of all of it. You just have to let us know and get us in touch with the family. We also have the CJD Foundation, which is an excellent resource, not just for patients and families, but also for healthcare practitioners, public health officials. CDC as well is an excellent resource. They always change their website links, so this is probably out of date. You can always email me directly. However, you have an extremely informed local resource in your state public health prion person, Rachel Straver, who is extremely active in the space. If you have any case of prion disease, we highly recommend that you refer them to Dr. Straver. She'll make sure that the family knows about autopsy, that everything's properly investigated. So please take advantage of this kind of precious resource, which not all states have, and she's quite good at her job. So So with that, these are the wonderful people that I work with. Again, thank you so much for your invitation. And if we have time, I'm happy to take questions.
Thank you so much. Fascinating. I have a couple quick questions, and then we've got some from our participants. Um, besides elk and deer, um, what other animals show prion diseases? I mean, don't squirrels, am I remembering correctly?
No,
No?
that was
Okay.
debunked. Yeah.
Oh, okay.
Yeah,
Yeah.
squirrels don't have natural prion disease.
Okay. Are there any other animals, or is it just
So they're scrapie with sheep and goat.
sheep? Yeah,
Bovine
cows.
form encephalopathy with cows and cattle. There's camels. There are things like mink, transmissible encephalopathy, and feline transmissible encephalopathy. They're not naturally occurring prion diseases. They were due to basically having their feed transmitted with BSC. So the only natural animals with prion disease that we know of is sheep, goat, cervids, cattle, and camels, and us.
Great. All right, I want to ask that one because we have another number in the chat, and let me find where they start. 1 second. What type of specimens pose the biggest risk to lab staff? And I think you talked about lab safety, but anything you want to add to that?
Yeah, I mean, it's really just dealing with brain tissue. And even then, I mean, realize that it's still difficult. Our main concern would be the reuse of neurosurgical transmission in another person because, then you're taking exposure to contaminated instruments and reintroducing it into a person in a way that we know transmits disease. That's not going to happen in most other instances.
Here's a question. So TEPHI does a lot of wastewater work, and someone has asked a question about detecting prions in wastewater. Has anybody ever looked at that?
No, not that I'm aware of.
Yeah, and you'd have to be excreting it through your
Yeah.
GI tract,
I
huh?
mean, this has been raised as a concern. Again, you do all kinds of interesting things when you do this work, right? I'm sure you know the same thing, but I learned all about deer carcass removal and leach it, right? So, I mean, that's an instance in which it might be a consideration, right? Because if you have a chronic wasting disease farm that or cervid dumping ground
Mm,
and that's near a water supply, that could be a potential concern. But I would think that practically that instance would be pretty rare.
yeah, and epidemiologically, well, the problem is, isn't it that the sporadic, you can't really tell if it was a transmission event. Um,
Well, I mean, that's why we do surveillance, right? So
yeah,
we've been doing surveillance for, I don't know, 28 years. So we know what the prions disease look like neuropathologically, and we use historical controls. And it's highly likely that if there is a novel prion disease, it's going to look different neuropathologically. Variant CJD looks very different from, so I think zoonotic illnesses, we probably would see a difference. Now, human to human, of course, it's probably going to look like whatever the initial human exposure
right,
was, right?
right.
So that is going to be difficult unless you have a known recognized exposure history.
Another question, is there a critical exposure dose for iatrogenic CJD, or I would think really for any of the prion diseases? And I think you talked about that a little bit, that
Yeah. I
most
mean, we know
people
that
don't.
in the lab that there
Yeah,
is. It's hard to do that in a standardized fashion clinically with iatrogenic CJD because it's not like we're experimentally, calculating the dose. But we do know that those batches of human growth hormone that had the higher titers of prions did have higher attack rates. So that would be an example of that, but we don't know what the exact dose would be. It's probably different for each person too, depending on your genetic background that increases or decreases your risk.
yeah. And that polymorphism 129, that
Right.
that makes a big difference in your susceptibility.
It does, yeah.
Correct. Yeah. So for CWD surveillance, looking for related variant CJD in people, would you expect to see something different on pathology or testing that would increase your suspicion? Or should we be looking at every CJD case for potential exposure to CWD contaminated venison?
Yeah, I think so. So, you're in Texas. Unfortunately, Texas is affected by chronic wasting disease. You have a lot of hunters, right? So, any case we see, and I know Rachel does this, we get a hunting history, we get a venison consumption
Mm.
history. And we do expect that the brain tissue would look different. It's a genetic illness. It started out as a deer prion. So, there has to be some fancy manipulation of the human prion to get it to convert. So it usually results in different neuropathology, like we saw with variant CJD. But yeah, definitely. I mean, consider it, get a hunting and venison consumption history. And if the family's open to autopsy, that would be ideal in all cases of suspected prion disease.
Another question, have there been any lab-acquired transmissions of prion diseases in the US? Are there special safety precautions for neuropathologists who work with sharps if you're doing brain dissections on deceased CJD patients?
Yeah. So there's been no known lab transmissions of prion disease in the US. I also note there's been no known clinical lab occupational transmission of prion disease. There have been a couple occupational exposures in research labs. Ironically, they weren't dealing with human prions, they were dealing with like super adapted strains of bovine spongiform encephalopathy, and it's thought that that's where they got it. So, again, we don't think that clinical people are at risk. I think it's different. If you're dealing with brain tissue, you are dealing with highly infectious material. So, I don't know what the instance that you're doing this with, but for example, cadaver labs, I mean, you would want to defer cadavers that had a rapidly progressive dementia. They should not go to a gross anatomy lab without proper testing, or, they really should just be excluded entirely. So there's ways to mitigate this just by history taking, right? But yeah, I think that would be the main instance that she's probably explaining.
Um, Two, I hope, quick ones. The squirrel debunking. It, it was just that there were a few cases and they happened to eat squirrel brains, right? And then you discovered it was not
Squirrels don't
prion
have
disease.
naturally
Yeah,
pre
yeah.
have
So it was
natural
just
prion
a
disease.
coincidence.
Right.
Yeah. I don't know if you know this, Texas Parks and Wildlife policy guidance for carcass disposal.
I do not know that. I bet you Rachel does though.
Yeah, yeah,
That's
I could
frustrating.
look on the website. And one last question from me. At the time of BSE in variant BSE in Great Britain, there was a lot of concern that we'd be seeing many more cases and cases longer than we've been seeing them. Why do you think the epi curve? I mean, I know it was more than 10 years, but still, given the long incubation period, um,
Yeah, I mean it's a zoonotic illness, right? So we know that the protein attaches to the protein and causes the misfold, right? But like and like, BSE prions are not similar to human prions. So there's the species barrier you have to overcome.
mm,
I think the resounding thought, and this might be what you're alluding to, is there's three genetic polymorphisms that codon
mhm,
129,
mhm.
and almost all of them were MM. And so we thought we would see other, um, curves that represent the other polymorphisms, much like what we saw with iatrogenic CJD and Kuru. We just haven't. And I think it's just because it was a very, very inefficiently transmitted illness.
Yeah, thank
So,
goodness.
yeah, right.
Um, and just and you might want to add to this list, but if the audience is interested, there's some really interesting books about prion diseases, about Kuru, about FFI, and um, Kurt Vonnegut wrote a book, Cat's Cradle, that
Mhm.
talks about ICE9 before we knew about prions, right? Talking about folding and how how the folding of an abnormal folding of one thing can affect the other things, which is what happens in prion disease. So, if you're interested in this, do some searching. One last question. Prions observed in primates, I guess not, given what you said.
Well, I mean, we can transmit it to the primates, but there doesn't appear to be a naturally
Natural. Okay.
occurring prion
Yeah.
disease.
Okay. Thank you so much. Fascinating.
Yeah.
Yeah.
You have a
And
great day.
hope to see everybody in July. We'll send out the details and let me know if you have suggestions.